Home stretch, 6-minute walk test. We just had a couple hours of our wonderful scales, and now we'll finish up with the 6-minute walk test. So maybe it's a good time to ask, who's done the 6-minute walk test here in any population? Ooh, that's good. How about who's done the 6-minute walk test in SMA? Okay. So of those who've done the 6-minute walk test, who's done it in Duchenne? Okay. So that's an important distinction, and when we get to the specifics about administering the scale in SMA, we can make sure to highlight some nuances or differences. But the 6-minute walk test is simply a test that measures the distance you walk up and down a 25-meter course. What we like about it is that it's objective, it's easily administered, it's safe, and it's known to be an evaluation of functional exercise capacity. It's representative of a person's ability because the intensity of the test is self-selected, so they're told to walk as far as they can in 6 minutes, and they set the pace. As we all probably know, it was initially designed for people with cardiopulmonary disease, but in 2019, 2020, it's widely adopted in several other conditions, neurological conditions, neuromuscular conditions, including Duchenne, myotonic dystrophy, myasthenia gravis, ALS. With regards to its validity and reliability in the SMA population, Sally led us at Columbia in a nice exercise in determining its reliability and validity. We showed that it had great test-retest reliability. So we did, when you compare two tests 1 month apart. And then for convergent validity, we found that the 6-minute walk test was nicely correlated with most of our motor function scales, the Hammersmith, TUG, 10-meter walk-run, with gait parameters as well as strength. Notably, it wasn't correlated as expected with FVC because in ambulant SMA patients, their FVC is typically normal, and it also wasn't correlated with knee extensor strength, and that's consistent with our observations and other observations. Their quads are so weak that they're not determining their gait function. We also showed that some criterion validity, that the 6-minute walk test distance was positively associated with their aerobic capacity, or VO2 max. Interestingly, we also reported that if you look at those who walk less than 300 meters, the 6-minute walk test is even more correlated with the VO2 max test, suggesting that the weaker patients, the 6-minute walk test is more representative of a maximum exercise, where those who walk more than 300 meters, the 6-minute walk test is more of a submaximal activity. Several papers, one of a paper that was born out of the PNCR in 2010, and a paper that was led by Elena Mazzone and the Italian group with Dr. Mercuri, is that the 6-minute walk test could distinguish between type 3A and type 3B. If you recall, I think yesterday one of the speakers, I'm not sure, Dr. DeVivo or Dr. Finkel or others, highlighted that the age of onset for symptoms in walkers usually determines the severity of the disease. So those who walk less than, who have symptom onset before the age of 3 are considered type 3A and have one trajectory, and maybe it was Dr. Parsons who said it, sorry. And then those who are symptom onset is after 3 years of age, they have a different trajectory and have maybe a milder form of SMA. And you can see here the 6-minute walk test can discriminate between those two groups, that the distance walks is a bit lower in the 3A versus the 3B patients. And we saw it in our study, and it was seen in the Italian study. The one experience we had, our initial experience with the 6-minute walk test, is we found that it was able to capture fatigue, so physiologic fatigue. And this was a work done out of the PNCR, and we studied 18 ambulatory patients and looked at the difference in velocity walked in the first minute versus the 6th minute, and found that they were significantly different. And what we found is that across the 6 minutes, there's an average 17% decrement. We've had some experience with this measure of fatigue over the years, and what we wanted to know is this fatigue unique to SMA, or is this just a function of weakness? So if it's a function of weakness, we'd expect that fatigue would be apparent in all the other diseases that we see in a neuromuscular clinic. And in our clinic, anybody who walks does the 6-minute walk test. So we looked at our clinic population and looked at a group of SMA patients, a group of Duchenne and Becker patients, a group of largely energy failure disease patients, so they had mitochondrial disease or a GLUT1 deficiency syndrome, and then a group of myasthenic patients. And what we found in this graph is that so on the x-axis for all these figures is the 6-minute walk test distance expressed as a % of predicted, so that we could compare across age groups. And then on the y is fatigue. And what we found is, despite a range of ability on 6-minute walk test in all the groups, only in SMA was there fatigue, and that fatigue was related to their 6-minute walk test distance. And so that suggested to us that maybe the fatigue was unique to SMA and had some other underlying mechanism. Admittedly, we were puzzled because myasthenia gravis is the hallmark of myasthenia gravis is fatigue, right? So and further, we know that from other work that's been done in mouse models that the neuromuscular junction, and we learned yesterday, the neuromuscular junction, like in myasthenia gravis, is implicated, is a problem in SMA. So we're a bit puzzled that why weren't we seeing patients with myasthenia gravis exhibiting fatigue. And what we ended up figuring out is that the population that does the 6-minute walk test in our neuromuscular clinic that have myasthenia gravis are treated. And so we had, in our paper, we reported on 2 case studies of untreated or undertreated myasthenics that were unable to complete the 6-minute walk test. And so certainly further work needs to be done, but this sort of further gauges our interest in this fatigue measure in the SMA population. Most recently, Dr. Mercuri and his group in Italy actually showed that the 6-minute walk test, fatigue on the 6-minute walk test, actually correlated with neuromuscular junction dysfunction with using repetitive nerve stimulation. And so they looked at a cohort of 15 children and adults and found that 9 of the 15 patients had repetitive nerve stimulation values that indicated that they had a decrement or a problem at the neuromuscular junction, and that decrement was correlated with fatigue. So I mentioned this earlier today. We also know that the 6-minute walk test is important in looking at the natural history of the disease. It demonstrates progressive loss of function over time, but most importantly, that there are vulnerable periods. So in the earliest or youngest children, we actually see a bit of an increase in this top left corner here. The mean change in 6-minute walk test distance per year is actually slightly upward. So they make some developmental gains in the youngest, and that's consistent with what we see in the non-ambulant population as well. But the adolescents are at the highest risk of loss of ambulation function. And then most recently, I think I have to update my slide because this was published in Muscle and Nerve a few months ago. We looked at ambulatory patients treated with nusinersen in the CS12 study, so the initial open label studies that included type 2 and type 3 patients that were spoken about a bit yesterday. So there were 14 patients, and they were followed over 3 years, treated with nusinersen. And what we found is, so the blue dots represent the change in 6-minute walk test distance, median change over the 3 years. And as mentioned yesterday, there was a 98-meter improvement, median 98-meter improvement over those 3 years in those subjects or participants. And the green represents the change in fatigue over those same times. And so what we found is that in addition to increases in walking distance, there was at least a stabilization, or if not a decrease, in fatigue in those same patients treated with nusinersen. So with that, I'll hand it over to Leslie to talk you through the test.
Thanks, Jackie. I think she did a beautiful job giving us a summary of the background of the 6-minute walk and the importance of what it can tell us in SMA. So by the show of hands in the room, you guys are pretty comfortable with the 6-minute walk test, but I think what we hope to give you is some details on the logistics of 6-minute walk in SMA and how we can really standardize it to make sure that we're all completing it in the same way and getting the same information. So obviously the required equipment for the 6-minute walk test is minimal. You need a hallway, but the big sticky situation about the hallway is it has to be long enough. So you need at least 25 meters. It's really ideal to have at least 30 meters so that you have room to actually turn around the cones. And it's ideal to have a tile or linoleum type floor. That would be preferred. If you have something like this low pile carpet, that is suitable as well. Just something that won't cause traction or difficulty with walking. You need floor tape to mark your pathway and to mark your meter distances. Obviously a stopwatch to record the time, and then 2 cones that you place on either end of the pathway so that the patient walking knows when and where to turn. And then also for our patients with SMA, you need Post-it note flags that are marked 1 through 6, because those are going to be your minute markers that you'll use while they're walking on the path. And then really 2 evaluators is ideal. 1 person to record the times, use the stopwatch, and then 1 person to mark the minute distance with the flags while they're walking behind the patient and monitoring the patient if for any reason there were any falls or any difficulty with the test. So this is what the course would look like, and you can see the 2 cones that we talked about and the meter marks along the line. And the start position, you would actually start them to the right of the line, and you're going to have the patient walk in a counterclockwise direction along the 25 meters. This is a Performa that we use to record the distances and all of the information that we need for the test. So there's a place to record height and weight, and then at each lap, so you can see there's lap 1 would be 25 meters. At the point in which they cross the cone along that first lap, you're going to record what time they did that. And then with each successive lap, you're recording the time. The timer, who is the person who's timing, will call out each minute, and at that time, the person that's walking with the patient then places the Post-it note on the floor at the position of the patient's back foot on the side of the line on which they're walking. So you're looking at that. And then we'll go over how you calculate the distance at each minute once the test is completed. There's also some additional information that can be helpful from a just descriptions and subjective information. You want to note if there was a fall, and potentially if there was a fall, were they able to get up on their own? Did they need assistance? Any kind of comments on different behavior or participation difficulties, especially in a younger population. So if you've got a new walker who's 3 or 4 year old, that can be difficult to keep them on task. So you may have to have a little bit more encouragement or guidance than you typically would, and it's important to make sure that you're noting that, because you're deviating away from what the standardization of the test really has been set out to be. So we do have detailed instructions for the patient. I will be the first to admit, especially the more that just kind of like you may have heard Terry said in the Hammersmith group, the kids start to know the test better than you do. And so I will be the first to say, this is the 5th time I've done this test with somebody, I kind of want to go lax on my instructions, but you do need to remember to try to keep it as standard as possible. So you're going to tell them that the object of the test is to walk as far as possible for 6 minutes. You're going to walk back and forth in this hallway. 6 minutes is a long time to walk, so you will be exerting yourself. And then you'll also tell them that they are permitted to slow down or to stop or to rest as necessary. And they may lean against the wall while resting, but you want to resume walking as soon as you're able. Because remember that the object is to walk as far as possible for 6 minutes without jogging or running. So those are your instructions. We also, in our patients with SMA, have standardized encouragement, which was adopted from the ATS guidelines. And you want to use not only the same kinds of encouragement, but also in even tones and those kinds of standard in a standard process. So at each minute, you might say you're doing well, you have 5 minutes to go, that's been a minute. And then of course, we talked about the fact that you'll record the time for every 25 meters walk, and the distance at each minute will be calculated. So just to kind of take you through, for those of you that have not done minute splits with a 6-minute walk test and how you calculate. So if I have a patient start the test and at a minute I place a Post-it note on that side of the path, then I'm going to record however many meters that is. It's probably about 16 meters. I'm going to record that 16 meters is my 1 minute distance. Okay. They continue to walk and they go around the cone, so they've gone 25 meters plus another 5 or 6 meters. So my minute 2 distance would be 30 meters. And then it just successively goes as you're walking along the pathway. So hopefully that makes sense. Okay. If you do have a patient that does fall during the test, ask them if they're okay or if they're hurt, if they're able to continue. If they're unable to resume standing, if they're unable to resume standing without assistance, then, or you can help them up if you need to, then the test can be continued if they're able, but just make sure that they're okay before continuing. Remember that the timer never stops. The timer does not stop when they fall, and the timer doesn't stop when they rest. So you want that fall or that rest time is part of the 6 minutes that they would be walking. If the patient needs cues, or I mentioned in your younger 3 or 4 year olds, those kinds of patients, if they need cues to stay on task, or for whatever reason aren't just having a bad day and aren't giving their best performance from a behavior standpoint, you want to provide encouragement as necessary, but try to keep it to a minimum and keep it as standard as possible. So just giving that little nudge that, remember, I want you to walk as far as you can in 6 minutes. Or remember, I want you to walk along that side on the line. So those kinds of words of encouragement are okay if you need to keep them on task. If they do need to stop and rest, it's fine that they do that, and you can remind them that they can lean against the wall and then continue whenever they feel able. And again, like I said before with the falls, you would not stop the timer. Comment section we talked about with the Performa, and so again, if there was to be a fall, you might give details as to what caused the fall and if they required assistance to stand or if there was any injury, any issues about the patient's participation, and then any comments about the validity of the test. If you feel like the test was compromised because you did have to give too much coaxing or encouragement, or they didn't stay on the path for the majority of the test, those kinds of things you can document. For our new walkers, those kids that are starting to gain the ability to take steps, you do have to kind of think about safety and consider how you're going to go about completing a 6-minute walk test with them. So you want to make sure that they are able to walk without support. They are permitted to walk barefoot if that is if that makes them more stable and makes it easier for them to walk. And then again, remember, they're permitted to stop and rest as much as they need to. They have to remain standing during that rest, but they can use the wall for support. If the child does go ahead and sit down, the test is stopped at that point and marked not completed if they stopped before the 6 minutes was up. From a strategy standpoint in those new walkers, you may need a rolling stool where you can sit behind the child so that you can guard them as they're walking. You can roll along behind them. You can also, if your hallway is very wide and they feel like they need to walk to the side of the pathway closer to the wall just for security, the feeling of security, then that is fine. You just don't want them to then use the wall as they walk along, because they're not actually walking independently if they're actually touching the wall as they walk. So you want to monitor that and make sure that that doesn't occur. And then, Jackie, you want to come over and we'll talk through the videos together? So we have 3 videos. We have a younger child who is actually the cute little boy that you guys saw in the Hammersmith breakout session. And then we have another older child, and then an adolescent, stronger child that we'll take a look at.
So this is the little boy that Sally and Terry showed. What's I like to highlight is this is the first minute, and he's walking pretty vigorously with that typical SMA gait.
I think Sally does a nice job of guarding, but it's definitely there's a trying not to pace.
See, who needs a fatigue variable? You just have this.
He's determined.
Importantly, he gets what the instructions are, even at 3.5 years old. Now you're seeing some more gait decompensations, more rest, a little collapse. It's definitely using more trunk. You could see that because Sally's working so hard to guard, there's another person there putting down stickers to. Now in the 6 minute, certainly. Shake it out, shake it out. So in this course here, each semicircle is a meter. So we have it embedded in the tile. I think that's the end.
Good. So this is he's an 18-year-old that was in the CS212 trial. So he's been on Spinraza for some amount of time. This was a clinic visit that he wanted to break his record of how far he could walk. So he's a competitive swimmer. He's a pretty competitive young man. So this is the first minute, and there's that arm swing that we see. And he does have plantar flexion contractures, so that limits him a little bit as well. But this is the first minute, and he's going pretty hard, pretty fast. Then I think it's interesting at this third minute, see how he's slowed down a little bit. That fatigue has set in, and he's definitely not moving as quickly as he was. Arm swing, I think, is probably pretty comparable to that first minute, but he definitely has a little bit more trunk lean, trunk compensation. So it's definite that he does start to slow down, even with as good as he does with all of his swimming and all of that kind of stuff. The family has chosen not to. The question was why we didn't do a TAL release. So this is minute 5, almost to minute 6. And again, now you can see that the turning is actually pretty difficult for him. I think his arm swing has gotten more significant, definitely slower, but still going at a pretty good pace. So it's just interesting there. He did beat his record. So this walk, he walked 501 meters. That's why I didn't follow behind him. I was just going the middle of the the middle of the road. Okay.
Want to take questions?
Yep. So that's what we have. Any questions for you guys?
Okay, so I'll try to summarize a couple questions that were asked here, and we'll start with some technical questions. So the technical ones have to do with the standard setup. If they don't have a standard setup of 25 meters, is it okay to use a different setup?
Yeah.
So I would encourage you to try to adhere to the ATS guidelines as much as possible. So in the ATS statement of 2001, it says course 20 to 30 meters. So anything shorter than 20 meters is probably insufficient, and it should be a straight line. And I still think that in order to call it the 6-minute walk test, the other parameters that Leslie outlined are important as well, like the surface and such.
Okay. And then the other question related to that is, if they cannot walk independently and need the use of assistive devices, is it okay to use it as long as you use it consistently? And then the second part of the question is there, are you looking into a possible modified 6-minute walk test where that is okay to use an assistive device if it's not okay to use it in the current 6-minute walk test?
Yeah. So the challenge in using an assistive device and following somebody longitudinally is that if they show improvement and then lose that assistive device, walker or crutches, they're likely to have a shorter walk distance, but really it's greater function. So say they did 200 meters with the walker, and then they achieved independent ambulation and did 75 meters without the walker. It actually looks like there's a decline instead of an improvement. So I think the best place to start is without an assistive device, especially walkers and crutches. And so you'd be surprised too that there is that sort of window of opportunity where they're walking pretty effectively with their assistive device and their brace, and maybe they can take 4 or 5 steps, 10 steps without their braces, barefoot. Or without the crutches, and that's actually valuable. So even if they stand for 5.5 of the 6 minutes and take 2 steps, wait, 2 steps weight. That's a nice baseline, so that if they make improvements and they go from walking 10 meters in 6 minutes to walking 25 or 50 meters, that is a notable and important documentation of their progression.
I had Jackie. Oh. No, maybe not. Oh man, I really wanted to use this really cool microphone. Oh, it's on there. I try to also follow Jackie's advice for the most part, but not having worked with a lot of older adults, we had a 52-year-old woman with type 3 SMA come in for Spinraza, and we did the Hammersmith and the Roam, and she only walks with a anterior rolling walker, and so I was a little bit kind of stumped on what to do. So I have been having her bring in her walker, and we've been doing the 6-minute walk test knowing that I can't compare it to our validity studies, and that walker could change over time. But what was really nice was a year later, she came back for her reevaluation at the 1-year mark, and I'd been seeing her up until then, and she thought, oh God, you're going to have me do the walk test again with my walker. And last time I saw her, we were doing the revised Hammersmith, which has the 10-meter walk run, and I said to her, hey, do you feel comfortable doing the 10-meter walk today? You look like you feel more confident with walking. And she reported walking more safely at work, and her coworkers had noted that. And so she was able to do the 10-meter walk test without an assistive device independently. So it was kind of nice to see, using both of those tools, and then maybe next time we'll transition to a little bit longer without the walker. So
Thank you.
So how about one more question? So with the 6-minute walk test, besides fatigue and distance walked, is it okay to look at other gait deviations and compensations and balance that may be associated with the gait pattern during this test?
Yeah, I think that's part of where the comments section comes in. I mean, if you want to continue to look at quality of gait and those kinds of parameters, I think it's important to consider that and show change over time if that quality changes as well. So I think the answer is, yes, it would be fine. Okay.
Thanks.
Thank you, guys.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.